Good evening. I'm Al Sue. I'm the chair of the Brookdale Department of Geriatrics and Palliative Medicine, and I have the pleasure of welcoming you to Mount Sinai and to the Douglas West Lecture. Every year, I tell the staff organizing this that the last thing that they need is someone to introduce Mrs. West, and then to have someone introduce the person who will introduce the speaker in order to get to eventually to the speaker, but they don't listen to me. So here I am, and I have the pleasure of introducing Susie West. I am proud to introduce the founder of the West Lectures, a Hertzberg Palliative Care Institute Advisory Committee board member and a longtime advocate for palliative care, and most importantly to me, a longtime volunteer to the department here at Mount Sinai, Susie West. Susie was first introduced to palliative care when she was referred to Dr. Diane Meyer, who's here somewhere, for the care of her late husband, Douglas West. There she is. Shortly after his death, in 1995, she generously endowed this lecture in the memory and honor of Dr. Meyer. Now, over the past 2 decades, Susie has volunteered for the Hertzberg Palliative Care Institute here at Mount Sinai, doing all sorts of things. She has developed and maintained our database of individuals who support our programs. She's organized the community outreach through our Speakers Bureau with Ms. Betty Kerr, and she's served tea and cookies for our patients and their families on the inpatient unit. Susie has been a fixture here at Mount Sinai in the department and in palliative medicine. She's been part of the team in many ways, and with her assistance and advocacy has been keen to the Institute and to its becoming a national leader in palliative care and the largest palliative care training program really in the world. With Susie's support and guidance, the West Lecture has become a largely, a hugely successful forum for discussing palliative care, aging research, and healthcare policy. And this lecture is a great example of how far palliative care has come, as well as how great of an impact Susie West and the West family has made in this field. So we have been so fortunate to have Susie and the West family by our side for the last 2 decades. Please welcome Susie.
Two decades is, I prefer 20 years. I don't know. Thank you, Dr. Sue. I want to welcome you to this landmark today. Today is the 20th Douglas West Memorial Lecture in Geriatrics and Palliative Medicine. My family, friends, and the Mount Sinai community come together to remember my husband, Doug, and to honor Dr. Diane Meyer, who cared for Doug during the difficult last 18 months of his life, when there was no formal palliative care at Mount Sinai, or I don't think anywhere else, right, Diane? Also, I wanted to shout out to our auxiliary board. It's our 100th anniversary of the Mount Sinai Auxiliary Board. And in their wonderful wisdoms, so many years ago, gave Dr. Meyer seed money to build our palliative care program. I am a very proud member of that board, and I wasn't even there on the board when they gave you the money, so it wasn't my influence. I influence them now, but not then. More news this year. It's almost a year since Mount Sinai and Beth Israel combined their palliative care programs. Thanks to Doctors Nate Goldstein and Steve Burns for spearheading the growth of the program at Mount Sinai Beth Israel, because our palliative care fellows program is the largest in the country. Our fellows have the opportunity to train in both hospitals, which have very different cultures. And more news, our expanded teaching and program gives training in the basics of palliative care to physicians and hospitalists who are not specialists in palliative medicine. This, in turn, allows our Mount Sinai teams to focus on the most complex cases throughout the hospital. Palliative care awareness is alive in the community. Oh, I forgot, I have to film. Excuse me. Palliative care awareness is alive in the community. 80 volunteers from Citicorp donated over 250 crocheted and knitted blankets for our patients and their families. Each blanket comes with a personal get well note from the maker. Congratulations to Citicorp, and I have a little example to show you. And I hear that we're getting about 250 more soon. So the volunteers at Citicorp are just incredible, and I can't get this out. So this is just an example. The note is missing, but there's always a note from the maker to whoever, either the family or the patients, and they are allowed to take them home with them. So we're very proud of that. Let's see, okay. So I think that's it. Thank you all for your interest in our work. I look forward to hearing what Dr. Sean Morrison has to tell us today. And I hope you will join us again for many, many more years in the future. Thank you.
Thank you, Susie. To introduce our speaker tonight, I'd like to introduce Stephen Schwartz. Stephen is president of the Brookdale Foundation Group and a member of the Mount Sinai Health System Board of Trustees. It is no accident that this is also called the Brookdale Department of Geriatrics and Palliative Medicine. For the past 56 years, the Schwartz family has set an example of focused and impactful philanthropy. And in many ways, this lecture, this department is an example of the impact that philanthropy has had. Under Stephen's leadership, the foundation has turned its attention to the needs of America's aging populations. Through direct support of our programs here at Mount Sinai, Stephen and the foundation leadership have carefully cultivated the fields of geriatrics and palliative medicine as we have come to know them today. They have shaped these fields through their philanthropy. And this is the best kind of advocacy through philanthropy, in this country. Sean, who is today's speaker, was a Brookdale National Fellow. I was a Brookdale National Fellow. There are several other Brookdale National Fellows here in the audience and at Mount Sinai. They have had a tremendous impact on our field. So I thank him, his wife Letty, and the entire Schwartz family. Their compassion and their vision continue to be our driving force as we focus on the needs and challenges of America's elderly and severely ill population. Stephen?
Let me begin by saying how honored I feel to have been asked to introduce Dr. Morrison tonight. I first learned of Sean Morrison in January 1996. He had applied for a 2-year Brookdale Fellowship, the purpose of which was to provide young investigators with research opportunities in geriatrics and foster their growth as leaders in the field of aging. Sean at that time was an assistant professor in the Brookdale Department of Geriatrics and co-director of the Palliative Care Institute at Mount Sinai Medical Center. The best 8 or 9 applicants were invited in for an interview. And so, in February 1996, I met Sean for the first time. My first impression of him was that he was extremely precocious, since he did not appear to be more than 15 or 16 years old. Unfortunately, my memory is not good enough for me to remember how the interview went, but I do have an excerpt from Sean's application that I would like to share with you. In his statement as to what kind of leadership role he planned to assume, he wrote, "My leadership goals are to enhance education regarding palliative care and establish myself as a leader and role model in geriatrics and palliative care." Shortly after the interview, and on March 7th, 1996, I had the pleasure of sending a letter to Sean, which contained in part the following. "I am pleased to inform you that the Brookdale Foundation has approved a fellowship award to your institution to support the research project you will be conducting. The fellowship program is designed to provide young investigators with research opportunities in geriatrics and to foster their growth as leaders in the field of aging." Now, let's fast forward 20 years to the present. Dr. Morrison is now the co-director of the Patty and J. Baker National Palliative Care Center, director of the National Palliative Care Research Center, vice chair for research at the Brookdale Department of Geriatrics and Palliative Medicine, director of the Hertzberg Palliative Care Institute, and the Herman Merkin Professor of Palliative Medicine in the ICANN School at Mount Sinai. And even more importantly to me, he has been my family's and my friend, medical advisor, and personal physician for these many years. He has also rendered hands-on palliative care to our friends when such care was desperately needed. I think we can all agree that Dr. Morrison has made good in the goals and ambitions he set for himself some 20 years ago. It is now with a great deal of pleasure that I have the privilege of introducing Dr. R. Sean Morrison.
Thank you for joining us tonight, which is extraordinarily the 20th anniversary of the first Douglas West lecture. And thank you, Mr. Schwartz, for really just a wonderful introduction. Al mentioned, and I am now going to skip all that I had to say about the Brookdale Foundation. Al mentioned the extraordinary contributions that Brookdale have made to the field of aging and recently palliative medicine in the United States. And I think I can say this with absolute certainty, the field would not be where it is today if it hadn't been for this relatively small family foundation in New York. As I said, Stephen and his family gave me the opportunity to spend time thinking about what I wanted to do and really started my career 20 years ago. And I said I've had the privilege of working with him on the board with Karen Hart, Rebecca Schaefer, Marianne Van Clay, who are the board members here for 20 years. Thank you very, very much for that. I also want to offer my immense thanks to Susie West, who is in the front seat of the convertible. And her children, Deborah and Philip, who are in the back seat and apparently not wearing seatbelts, it looks like. There weren't any of those, for their incredible support for over 20 years. Philip, for spectacular meals in California at your restaurant range. For Deborah, for your companionship and professional collaboration these past couple of years. And most of all, to all of you for your friendship. As you've heard, Susie's unwavering support for their palliative care program over the past 20 years has really been quite transformative. I also want to spend a moment to remember Doug West and his life, Susie's husband, and Deborah and Philip's father. I never had the privilege to meet Mr. West, and I'm actually very sorry. I am very sorry that I didn't. I am told that this is the prototypical Doug West photo because he was never without his pipe. Susie says that even when the phone rang in the apartment, he would take several more puffs, wait for somebody else to answer the phone, take a few more, and when they didn't, finally put it down. He was a man who was deeply interested in life. There were always a million fun projects going around in his apartment when his kids were growing up. He was a wine collector. I told you I liked him. And Deborah remembers actually steaming the labels off the wine bottles with him to put them in his collection. Building cactus gardens from the wine bottles, is that correct?
Also had a glass cutting machine in our apartment so we could use glass.
Yes, and he had a glass cutting machine so he could make glasses out of the wine bottles. He did that at midnight.
In our bedroom.
But I am also told what he enjoyed most about his work was mentoring and teaching junior analysts. And I wish he could be here to see the number of people that we have been able to teach about palliative care over 20 years. I think he would also be thrilled, except perhaps for this year, with the quality and stature of the people that we have been able to bring to Mount Sinai. We have brought the father and the mother of geriatrics and palliative medicine, respectively, Bob Butler and Dame Cicely. We have had medical writers. We've had journalists. We've had medical writers. We've had leaders and pioneers in the field of palliative medicine. We've had caregivers and patients. We have had other writers. And we truly have had the rock star of modern medicine, Atul Gawande, in Stern last year. So what would I like to do today? There's a couple of things. First of all, what I'd like to do is really reflect on many of the teachings and the words that we've heard in this lecture hall, and hopefully convince you not only of the importance of palliative care, but of the fact that I think that the principles and practices of our specialty are appropriately transforming how we think about healthcare and how we deliver it in this country in 2016. And I'd like to make this argument in three ways with you. First, I'd like to briefly review the history of modern medicine, essentially for us to understand how we got where we are today. Secondly, I'm going to argue that there is a fundamental mismatch between health and healthcare in the 21st century, and this relates directly to how medicine has developed in this country. And finally, I'm going to discuss how palliative care can, and I would say is, transforming healthcare for citizens of the United States. Does that work for people? Please tell me yes. If it doesn't, you are free to leave now. I have a big enough ego that I can probably take it. But I want to begin by really focusing on what has happened in the past 150 years. And what this slide shows is the average life expectancy from the time that the first Aboriginals walked across the ice to inhabit the United States up until our present day. And what I would like to point out to you is that human life expectancy in the United States stayed almost exactly the same, somewhere between 30 and 40 years, for almost 20,000 years. And it is only very recently, sort of a wink in time, that we have seen this extraordinary jump in human life expectancy. If we go back just 100 years, look at what the leading causes of death were in the United States: pneumonia and influenza, tuberculosis, and gastrointestinal illnesses like cholera. Today, we have cures for every single one of these diseases. Childhood mortality is now a tragic, isolated incident rather than the norm. And we have turned previously fatal diseases like diabetes and hypertension into chronic illnesses. And in fact, if we look at the leading causes of death right now, they are, for the most part, chronic illness. 80% of us are going to die of heart disease, cancer, lung disease, stroke, or dementia. And I might even argue that for many people with cancer, this is a chronic illness which is going to span many, many years. So this should be a relatively extraordinary time for us. In less than a century, we have doubled human life expectancy, eliminated the leading causes of death in the United States, and turned previously fatal diseases into chronic illnesses, which with most of us will live for many, many years. Yet, if we think about it, and you look around this room, how many are really happy with the healthcare system that we have right now? If you believe the national surveys, about 16% of us are truly happy with the healthcare we have now. And if we look specifically at the data they get rather distressing. We've achieved longevity, but we have achieved it at a cost. 60% of us over the age of 75 who develop one of these chronic illnesses will have daily pain or another distressing symptom. That will be routine for our everyday life. Over 65 million of us right now are caregivers, and 90% of us who are caregivers say that we desperately need more help to take care of our seriously ill loved one. 1 million of us will declare personal bankruptcy because of healthcare costs, and 2/3 of us will die in a nursing home or in a hospital. In the year before our death, 80% of us will have wanted to have spent more time with our doctor, and we won't have gotten it. Half of us will not have had our emotional needs met, and 1 in 5 will need more help with our symptoms. And it's not like we're not spending a lot of money to get these results. We're spending 18% of our GDP in healthcare costs. That's 1.5 times more than our next leading high-income country spends on healthcare. And in fact, quoting the Institute of Medicine, between the healthcare that we have now and the healthcare that we could have lies not just a gap, but a chasm. And who's to blame for all of this? Is it the doctors? Is it our fault? Is it the patient's fault? How about the pharmaceutical companies? The government? The insurance companies? I would say yes, 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 and then no. Because I think if we really want to understand why we are in the situation we are, we need to go back until the 1800s. So this is the modern community hospital of the 1800s. The center of social and economic life in the United States 150 years ago was the home, and the locus of care for the sick was in the person's home. Hospitals existed, but they existed almost exclusively for the care of the poor or for the mentally ill. So where's the doctor in this picture, folks? And I will give you a hint. It is not the pensive-looking smart guy sitting right here. The doctor in this picture is right here. Because 150 years ago, women were expected to deal with illness. They were expected to keep a stock of remedies on hand in their house, and they were supposed to consult a physician only when needed, and they should be needed very, very rarely. Consulting a physician before 1900 was not, by the way, without risk, because if you were lucky, you were prescribed rest and diet. If you were unlucky, you received modern medical treatment. So consider George Washington, who, after a relatively successful stint on Broadway, retired to Mount Vernon. And George Washington went riding one day, and it was a little bit wet and a little bit cold, and he came back with the sniffles, which, by the way, was because he got a virus, not because he got cold. And he went to bed, and his illness progressed. And early the next morning, he woke up with a sore throat and difficulty breathing. Not because he had pneumonia, but because his throat was so red and inflamed, he couldn't swallow, and he was having trouble getting air in. Unfortunately for George, Martha called the doctor. And over the course of the next 24 hours, his doctors removed 40% of his blood by bloodletting. They applied Spanish fly to his throat, which caused the development of these horrifically excruciating, painful blisters, because this was to draw out the bad humors. He was then given a mixture of mercury and antimony, forced to vomit, which was probably good because the mercury came out. And then when all of this failed to work, had Spanish fly applied to his arms, his legs, and his chest in order not only to draw out more bad humors, but to recalibrate his fluid balance. And unfortunately, none of these efforts worked. And despite the best efforts of his doctors, and perhaps because of the best efforts of his doctors, he died later that day. However, as noted in this picture, before he died, he graciously thanked all of his physicians for their care. Prior to 1900, this was the best that modern medicine had to offer us. So let's fast forward and let's move to the end of the 19th century, and we're going to zoom in on that life expectancy graph that I showed you at the beginning. So as you can see, clearly something dramatic happened here, right? What was it? Anybody want to guess? Antibiotics, you're about 100 years too early, but close. So the germ theory of disease. Louis Pasteur in France and Robert Koch in Germany conclusively demonstrated that it was germs, not bad humors, that caused disease. And the effects of that were astounding. Vaccinations, sterile surgical technique, and sanitation rapidly resulted in a jump in human life expectancy that we had never seen in 20,000 years. In fact, in the 10 years between 1885 and 1905, human life expectancy in the United States jumped 10 years. And in fact, it's probably not an understatement to say that the single most effective healthcare intervention in history was the development of the modern sewer. When we figured out that separating human waste from drinking water was a really good idea, this doubles life expectancy in our country. And with our advances in the understanding of disease, medicine rapidly transformed from an art into a science. Sir William Osler, by the way, was a Canadian physician who was lured to the US to start the first medical school in Baltimore, the Johns Hopkins University, became the father of American medicine. Oh, by the way, if you would like, you may visit Sir William's boyhood home, which is now a lovely B&B in Dundas, Ontario. And the reason I say this is that it is very close to lovely wines on the Niagara Vineyard and is actually right beside the town that I grew up in. So for those of you who like, you can stay at Osler's boyhood home. But seriously, major innovations in microbiology, physical diagnosis, the use of existing imaging techniques. We had had x-rays around for a long time, but they hadn't been useful in medicine, fundamentally altered the role of the physician in the United States. Under Osler's leadership and teaching, we became detectives, seeking to understand the scientific basis of disease, and our role became one of a diagnostician. The goal was to see, quite honestly, if you could conclusively determine which disease you had, in the hopes that we actually might have a treatment for you. Unfortunately, we did a lot of diagnosis, but not a lot of treatment. Because if you had a cancer or abscess, we could take that out surgically, and that was good news. If we diagnosed you with congestive heart failure, we'd bleed a pint of blood for you. That is the modern day water pill, by the way. We could give you an extract of the plant digitalis, and we could put you under a big oxygen tent to help you breathe better. And if you had the right type of pneumonia, we could give you an anti-serum. If you had almost anything else, we really could tell you if you were going to get better or if you were going to get worse. And that's about all we could do. Quite frankly, up until about 1915, doctoring was pretty simple. We listened to our patient's history. We did a very good and comprehensive physical examination. We looked at x-rays. We looked at blood and urine through microscopes. We identified what was wrong with you. And quite honestly, we sat by and watched while nature took its course, and perhaps we helped it along the way. And what of hospitals? The changes in the role of the physician from 1890 to 1950 also corresponded to the rise of the modern American hospital. As I said before, prior to 1900, hospitals existed largely for the treatment of either the poor or the mentally ill, And for the wealthy in this country, they were primarily seen as a philanthropic venture, a way to put your name on a building to take care of the underserved in your community. For everybody else, hospitals were essentially attractive buildings. With Osler's arrival at Hopkins, however, the role of the hospital changed as well. It became the site for medical research and education. The hospital really became the laboratory where patients and diseases for the first time were concentrated in one place. Young physicians were able to learn the profession from a concentrated collection of real patients. This is Osler teaching at Hopkins. And the experienced physicians could advance the science by having their specimens readily available. They didn't have to go from house to house to house to do their science and experiments. And what about the patients? How did hospitals serve patients? Well, except for surgical care, the hospital's use for our patients was primarily good for the fact that it provided warmth, you could rest, you could have good food, clean laundry, and really the opportunity to serve as a textbook for the young medical student. And then the 1950s. And two really dramatic things happened. Obviously, we got rock and roll. And the other, perhaps of equal importance, where's my audience participant? The other thing that happened in the 1950s was that antibiotics came into standard clinical practice in the United States. Antibiotics were actually discovered, penicillin was discovered in 1928. As we'll talk about later, they actually didn't come into common clinical practice until the 1950s. And penicillin and the subsequent antibiotics that came fundamentally altered medicine in a way that we haven't seen since Pasteur and Koch. Overnight, patients with previously fatal illnesses became miraculously cured. And medicine transitioned from a practice focused almost exclusively on diagnosis to one on treatment and cure. And cure here really is the key word. Because for the first time in human history, doctors had the ability to predictably and reliably extend a person's life and to prevent death. Moreover, these miracles, and in the early days of penicillin, they truly were miracles, happened in a highly visible fashion. We saw the effect of sanitation through our statistics. And public health occurred at a societal level. However, the cure of cancer, the survival of a heart attack, the successful treatment of pneumonia, these changes were happening at the bedside of our patients. And our families and our friends saw them. And we as physicians began to see them. And quite honestly, I don't think it's an understatement to say that for the first time we began to believe that death and illness could be defeated. And as this era of modern medicine evolved, the language of medicine changed. And the language, quite honestly, became quite violent. For example, we declared war on cancer in 1971, where Nixon initiated, among others, the National Cancer Institute. We talk about beating AIDS, conquering heart disease, and death, when it came, typically followed a relatively long battle against disease. And like death in any battle, it was often pretty violent and traumatic. In the 4 years that I spent as a medical student at the University of Chicago between 1986 and 1990, I never, ever witnessed what I would consider to be a peaceful death. Every single death I saw as a medical student occurred following an attempt at cardiopulmonary resuscitation, unexpectedly in the operating room, or in an intensive care unit. Following the unusual patient in the 1980s who opted to forego a life-sustaining treatment, or even opted to be cared for at home on hospice, was simply not seen as an appropriate or valuable learning experience for a medical student. because in many respects it represented the failure of American medicine. And the other change that we saw that began in the 1950s was that medicine became exponentially and increasingly complex. In the 1950s, a physician, or at least a smart physician, could conceivably hold all of the medical knowledge in his brain. And unfortunately, it was his brain back then. Think about three conditions: infections, high blood pressure, and diabetes. In 1953, we had one medicine for each of those diseases: penicillin, hydralazine, and insulin. In 2016, we now have almost 150 antibiotics, 140 antihypertensives, and over 40 medications for diabetes, including 4 to 5 different forms of insulin, depending on how you count it. In 2015, there were just over 500 papers published on the treatment of breast cancer alone. We can't keep that amount of information in a single brain. So how do we cope? We specialize, and indeed we subspecialize. And in fact, right now we have a specialist for almost every organ system, and disease. This is a glimpse of Mount Sinai specialists, so that we can remember and cope with the increasing amount of knowledge that's required to practice medicine in 2016. I remember last year when I walked into the room of one of the patients as on my palliative care rotation, I was the 12th specialist to have seen that physician over the course of 5 days in our hospital. You know, it's like repairing a house now, right? You know, 100 years ago, one person, like my grandfather, built his house. And now we have plumbers, we have painters, we have electricians, we have roofers, we have floorers, we have cabinet makers, we got the air conditioning guy or gal. The problem is that human beings aren't really like houses. And more to the point, there is no person in medicine who really is the contractor, who's in charge of making sure that all of the parts get built and built well. And the other problem is there is no building inspector either. So once you do all the work, there's nobody actually looks at it and says, we did it well or we did it right. And so by the late 1970s and into the 1980s, some folks, some really smart people in medicine, began to think about where are we going and what are we doing? Leon Kass, who is a University of Chicago bioethicist, sounded quite a stark cry of alarm in 1980 in an article that he wrote in the Journal of the American Medical Association called What is the Patient's Good? And what Kass writes is, if medicine takes aim at death, prevention, rather than at health and relief of suffering, if it regards every death as premature, as a failure of today's medicine, but avoidable by tomorrow, then it is tacitly asserting that its true goal is bodily immortality. Physicians should try to keep their eyes on the main business, restoring and correcting what can be corrected and restored, always acknowledging that death will and must come, that health is a mortal good, and that as embodying beings, we are fragile beings that must stop sooner or later, medicine or no medicine. And I think by the late 80s and the early 90s, many of us in medicine were beginning to realize that something was wrong. For me, this happened really when I moved to New York City to begin my internal medicine residency over at Cornell. And it was really sort of three experiences that fundamentally changed how I saw my role as a physician and what I wanted to do in healthcare. So I began my internship in 1990. That's right after you come out of medical school. It's the next stage of medical training at Cornell, right in the midst of the worst of the AIDS epidemic, for those of you who remember those days. And midway through that year, I remember wheeling a young man, exactly my age, from the floor into the intensive care unit where I was doing my rotation. He was breathing about 40 times a minute. He was visibly exhausted. and had pneumocystis pneumonia. And all of us knew, as we brought him down, that his odds of leaving the intensive care unit alive were essentially zero, infinitesimally small. And it was my role as the intern to go talk to this person, this kid, about whether or not he would want to be placed on a ventilator, because it was pretty clear that he wasn't going to be able to breathe by himself anymore. He was just too exhausted. And quite honestly, I had absolutely no idea what to say. And my resident, my superior, who happened to be a year older than I am, wasn't terribly helpful either. And before I could even begin a conversation with my patient, he looked up at me in a very straightforward way and said, "Am I going to die?" And I had absolutely no answer to that. I knew enough to know that it was not a yes or no answer. But beyond that, I was just stunned. And clearly, at the time, I did not handle it very well, because 2 years later, as I'm walking on to start my rotation on what then we had an entire floor for the treatment of AIDS, I walked into the room, and the patient who had just been admitted sat up in bed, looked up, pointed at me, and said, "You're the son of a bitch that told me I was going to die." That clearly was not an empathic encounter with him. So, the second experience. A year later, I was a junior resident. I got called basically in the middle of the day. It was my mother sobbing to say that she had just been diagnosed with inflammatory breast cancer. For those of you who are not in the medical field, that is not a good prognosis. And for a year and a half before she died, her time was spent going back and forth to doctors' offices, several surgeries, radiation therapy, multiple courses of chemotherapy. And indeed, for most of the last year of her life, lived with daily pain, nausea, itching, fatigue, tremendous emotional distress. And all that her doctors, and including her son, who was a doctor, would tell her, or could tell her, was, when the treatments work, you'll feel a lot better. And I think all of us in our hearts knew that the treatments actually weren't going to work. But the reality is none of us knew what the alternative was, or if there was an alternative. And then the third experience happened a year later. I am now a senior resident. Smart enough to know what I'm doing, but just too smart, or just smart enough to be dangerous. And I was running a team on the regular floor, and I admitted a woman, 75-year-old, with a slowly progressive cancer out of the intensive care unit, who had ended up there because she couldn't breathe. And her lungs had failed badly enough that she couldn't get off the ventilator. She was sort of permanently attached to this machine. And she got up to the floor, and I spent days, turning into weeks, single-handedly trying to wean her from the ventilator. When we went around in the morning, nobody went in to see her with me, because we all knew that it really wasn't going to be helpful, and we had lots of other people to see who truly needed our medical knowledge. And our attending physician said, "Oh, we don't need to see Mrs. today. Let's keep going." So her human contact with the medical profession was somebody coming in and lying to her, essentially saying that, I'm going to get you off this ventilator. And fortunately for her, and I think fortunately for me, is the teaching attending changed. And young, very humane, very smart pulmonologist took over and said, "Sean, she's dying. What are we doing?" And said, "Are we really helping her to achieve her goals? And quite honestly, nobody knew what they were because nobody had talked to her. And are we truly trying to achieve our goals? And that was really the first time that somebody had looked at me and said, there might be another way forward. And I don't think it was just in our hearts and in the writings this began to happen. Out in the real world, the gaps and inadequacies of care for the seriously ill and those near their end of life were really becoming apparent. And this was no more so true than in the early days of AIDS. The AIDS epidemic of the 80s and 90s struck a generation of young Americans, resulting in months to years of unbelievable and untreated suffering. And AIDS was different than cancer. AIDS struck young people. It was really visible. It was associated with tremendous symptom burden. The average number of symptoms for somebody with cancer is 4. In the 1990s, when we didn't have highly effective antiretroviral therapy, the average number of symptoms in somebody with AIDS was 9 to 12. It was scary, and it was contagious. And it was almost universally fatal. I don't know, many of you may remember when Magic Johnson announced that he had HIV, and he was adamant that he was going to live with this disease and be cured. And I remember all the young doctors I was standing around with shaking their heads going, not going to happen. 20 years later, who was right? And by the end of the 90s, almost all of us knew somebody who was affected by AIDS, and all of us in medicine had cared for somebody who had AIDS. And right in the midst of AIDS came the study to understand prognoses and preferences for outcomes of risks of treatment in the Journal of the American Medical Association. Published in 1995, I'm not going to read that again. Support, as it became to be known, was the largest study to date of what it was like to have a serious illness in one of the 5 leading American hospitals in the United States. And the results of support were quite appalling. There's just no other way of saying that. Over a third of people in 5 of the nation's best teaching hospitals spent the last 10 days of their lives in an intensive care unit on a ventilator. 40 to 60% reported moderate to severe pain after a full week into the hospital. This wasn't just on admission. They'd been in one of our best hospitals for a week and still were having moderate to severe pain. And a third of families lost most of their savings. And finally, the 1990s saw the rise of the assisted suicide movement. 130 Americans became so terrified at what the end of their life was going to be like that they preferred to die in the back of Jack Kevorkian's VW minibus than to continue to live in our modern healthcare system. And by 1997, with the passage of the Oregon Death with Dignity Act legalizing assisted suicide in Oregon, the choice available to most patients and families was A, suffer intensely as we let modern medicine take its course, or B, end your life early so as to prevent that from happening. Clearly, there had to be a better option. In fact, there was. At the time that all of this was occurring, a relatively small group of academic physicians had begun to adopt the principles of hospice into modern medical practice. Hospice had been developed in the 1960s in England, came over to the United States in the 1970s as an alternative care system for the dying. It focused really on those right at the end of life who opted to forgo curative and life-prolonging treatments. It was provided essentially by nurses, and it was provided in the home. And it indeed offered a platform or a model for thinking about how we take care of the seriously ill. And early leaders like Charles von Gutten, who was one of the West lecturers at the beginning of the series, said, why should you have to be dying to have your suffering relieved? I mean, why should you have to get the end of your life to have your suffering relieved? And from this very, very simple premise came modern palliative care. And palliative care truly was different. It focused on the most complex and vulnerable patient population, the seriously ill. It began by seeing patients not as organs or a collection of organ systems, but as a whole person. And the key to quality was not to start by fixing each individual part, hoping that if you did that, the entire person would get fixed, but to start from the patient's and family's perspective and begin with what was important to them and focus on that goal. Pain and other symptoms weren't just clues that led you to the right diagnosis with the mistaken belief that if you got to the right diagnosis, cured that, everything would get better, but they were important in and of themselves. It also recognized that the needs of the seriously ill extended beyond the realm and the knowledge base of the doctor. Palliative care teams were developed as being transdisciplinary, and transdisciplinary is an important word because coined in the 1970s, what it means is that strategies cross discipline boundaries. And what it does is it allows an entire team to create a holistic approach that each disciplines can't do separately, the way that we do in specialized medicine, where everybody takes a component, or the whole team sort of sees the person together and each person takes their core component of it. But it really means a team working together. And finally, unlike hospice, these early thought leaders realized that all seriously ill patients, children's, adults, those we expect to cure, those we expect to live for a long period of time, those who are expected to die, and most importantly, and as importantly, their healthcare clinicians truly needed an added layer of support, that medicine, particularly for the seriously ill, had just become too complex. And we were really fortunate, because at the same time that academic medicine had a good idea, and many of you know there are lots of good ideas that float out there and nothing actually ever happens, we had two very large and committed foundations who were willing to invest in the idea and help to scale it nationally. The Open Society Institute, or OSI, and the Robert Wood Johnson Foundation, or RWJ. And this partnership between private sector philanthropy and academic medicine essentially created and scaled a brand new specialty, and I would say they did it brilliantly. So what did OSI do? OSI invested in people. And over an 8-year period, they funded leaders in academic medicine in 75 of the nation's leading medical schools, thereby essentially ensuring that palliative care was a presence within the infrastructure of organized medicine and with the infrastructure of our teaching hospitals. Diane and I think we are down here. I'm getting there. Diane is kibitzing. She can't let me go through an entire lecture without kibitzing. Diane and I, and a nurse colleague of ours who was here at Mount Sinai, Jane Morris, who's there, and another physician, Judy Ehrenheim, began a program of education in palliative medicine at Mount Sinai with OSI funds. And that, in 1995, was the beginning of palliative care here. OSI grantees, when we look back at what they accomplished, they developed the official subspecialty of palliative medicine within the American Board of Medical Specialties, so it became recognized as an official subspecialty in modern American medicine. They created new academic journals, giving the field a legitimacy. They started postgraduate fellowship training programs, again, to begin to train and teach the next generation of physicians. And they developed new and innovative clinical programs in palliative medicine, like the one here at Mount Sinai. And, I can't spend 45 minutes talking without, talking about the research aspect of it. And, some of us research wonks did some important things too, that really demonstrated the importance of palliative care to American medicine. We demonstrated that palliative care relieved patient symptoms. And it did that without hastening death. That it improved patient and family satisfaction with care and family outcomes at the setting of illness. It increased survival. And perhaps as importantly, given the rising cost of healthcare in this country, it did so reducing costs as compared to traditional healthcare. Research done primarily at this institution said that when you coordinate care, match treatments to those goals, the average U.S. hospital saves about $3.5 million per year. There's about 1,900 hospitals in the United States. I will let you do the math and figure out what that works out to. In contrast, RWJ focused on system change. And RWJ established a national program office called the Center to Advance Palliative Care, or CAPSI, at Mount Sinai. And more importantly, they convinced Diane Meyer to lead it. Now part of the Baker Center, with the National Palliative Care Center here, Mount Sinai and CAPSI, under Diane's leadership, has quite honestly singularly transformed how we care for the seriously ill in this country. CAPSI's original idea was singular, it was straightforward, and it was brilliant. Develop a business and quality case for palliative care by essentially adopting academic research into translatable, real-world products, and essentially create straightforward technical assistance that would allow every hospital to follow a recipe to develop a palliative care program. It was essentially the joy of cooking for medicine, although in a digital age. I think what's also as important is that CAPSI created a national community for palliative care. Diane likes to call this a tribe, but it really was a community of administrators, clinicians, and other advocates who could tweak, adopt, and implement this new palliative care innovation rapidly and in real time, not medical time. How long did it take penicillin to move into medical practice? 1928 to probably 1954. Palliative care did that in less than 10 years, or maybe just a little over. 2003, 25% of hospitals had a palliative care team. 2014, over 2/3. 90% of hospitals like Mount Sinai now have a palliative care team, and almost 100% of every single teaching hospital where all of us learn the practice of medicine have palliative care teams. 3 out of 4 Americans now live in a community that has a palliative care team. So conceivably, they have access. Although, there are some parts of the country where you might want to live, and there are some parts of the country where you may not. In sum, OSI, I would say, created the foundation of palliative care, and RWJ and CAPSI scaled it nationally. So, what will it take to complete the transformation, to better meet the needs of our patient population? And yes, sorry, Dr. Sue, I did need to use a hockey metaphor. So, I've got really 3 goals that I would like us to accomplish by 2020. The first is that all palliative care, or all seriously ill patients, will know to request palliative care in the setting of serious illness, that all healthcare professionals will be able to deliver it, and that all healthcare institutions will be able to support it. Essentially, we really do need to make palliative care everywhere, because I think that's what we would all want for ourselves and for our families. So how do we make that happen? First, we need a workforce. There's one palliative medicine physician for every 1,700 people with serious illness in this country. We will never have enough specialists to treat everybody. So we need to have a dual approach. The first is we need to expand our fellowship training program, because we need the specialists to be the teachers, the mentors, the researchers, and the people to take care of the most complicated patient population. But we also need non-specialists. I spent 4 years at the University of Chicago, 3 years New York Hospital Cornell, 3 years here, and had 30-minute lecture in pain that happened in the first year pharmacology course that dealt with how opioids are metabolized in the liver and excreted in the kidney. That is not useful knowledge when I sit at the bedside of a patient. In fact, I know more about this fishworm than I did about pain when I left medical school. This is Diphyllobotrym latum. I've never seen a case of it, although it scared me off sushi for a long period of time. We have an entire generation of doctors just like me. So we really need to think about how we're going to train all of those in practice, and all of those who are coming up. And I think one of the things is I'm so excited about what CAPC has done in terms of scaling this curriculum is this educational initiative, which essentially puts all of palliative care on your iPad. Thank you, Bryn Bowman, if she's in the room, and Andy Esch. We also need to teach some pretty fundamental communication skills. Why is this funny? If I replace this with, I really don't know, there's no easy way I can treat your hypertension, so I'm sending you to someone who can, how many would find the cartoon funny? What's the fundamental belief here, folks? It's that we come out of the womb being able to communicate, or we become pathologists or radiologists. I had as much communication training as, I don't know, if I had asked Philip West in the front row to go in and tell somebody that they had cancer. Philip and I have had the exact same amount of training in how to do that. Would you ever go to a surgeon who had had the amount of training as Mr. West has had? Absolutely not. How do we teach surgery? We give people a book to read, and they go home and read it the night before the operation. They watch the operation the next day. After that, if they're lucky, or if they think they're lucky, they get to hold a retractor. They might get to throw a stitch or two at the end. Then they do part of the operation, then the whole operation. And then, only then, do we turn them loose with real patients. We should teach communication, and we do here the exact same way. You go home with a book, and we have a really short book. You practice with somebody else. Then you practice with a standardized patient, an actor. You do a part of a conversation that's supervised by an experienced physician. They give you feedback. You do a whole conversation. Your attending physician, they give you feedback again. And then only when you are competent are you turned loose with real people. As I said, I didn't know how to respond to that young AIDS patient who asked me, am I going to die? But I got to tell you, as an internist, I can still throw a stitch. We've got to address the knowledge gap. This is work by Laura Gelfman. She's sitting in the back. She looked at the number of research publications in cancer for 2 periods of time versus palliative care. You come into my office and you have hypertension. As I said, I have 140 medications to choose from. In fact, I can select one that matches your stock portfolio if you would like. You come into my office with severe pain. I have one class of medication. They're called opioids, and we are having a little bit of difficulty with opioids right now, as you may have discovered. And we spend appallingly little money on research that is going to improve quality of life for people, patients and families. 0.2% of all our NIH dollars go to palliative care research or research focused on improving quality of life. By the way, who funds the NIH? Anybody? You do. It is all taxpayer dollars. So you actually do have a say. And your congressperson and your senator truly has a say in where this funding is going. I'm going to skip that. And I would suggest, quite honestly, that we need one more set of actions to effectively, what I would say is complete the transformation of American medicine. And I think all of us who are working in palliative care need your help to do that. She's in the audience, and she's given me permission to show this picture, so I will do that. I had the privilege of caring for Clay Felker, who was the editor and founder of New York Magazine, and the husband of one of our West lecturers, the author and journalist Gail Sheehy. And Clay had experienced, before I took care of him, multiple visits to the emergency department, multiple hospitalizations, in the 6 months before I became his doctor. I think it was a revolving door of back to the hospital, home, back to the hospital. And quite honestly, he and Gail were quite desperate. All Clay wanted to be was at home and to be well. And all Gail wanted to do was to make that happen. And I will never, ever forget at our first meeting when she turned to me and said, "I feel so guilty. What am I doing wrong?" The answer, of course, is nothing. She was doing nothing wrong. Yet we accept that it's our fault, and we can't believe this is happening because we don't know there's an alternative. And there is an alternative. And what I'd want, actually not really want, but need you to do, is to begin to demand it. Don't tell anyone that palliative care isn't available, that it isn't all right for you, that it's not yet time. You know, we have a new drug. It makes you feel better, makes your families feel better, makes you live longer, and you know what? It's relatively cheap compared to the alternative. Why wouldn't all of us want this? And I want to close by telling you about a quite remarkable young woman. This is Dr. Christina Savasta. She's a graduate of our Mount Sinai residency program. She also gave me permission to share her story. About 20 months ago, just 7 weeks after the birth of her first child, Christina went to the hospital, to the emergency department with difficulty breathing. And when the emergency physician sat down in front of her with a quite serious look on her face and said, "We found something very concerning on your x-ray," Christina's doctor's instincts kicked in, because we all know when somebody says we found something concerning on your x-ray what that diagnosis is. And that diagnosis is cancer. Her diagnosis was a primary mediastinal B-cell lymphoma. That's a long way of saying it's a pretty bad lymphoma. But the good news is it's curable in 2015. It's a curable form of cancer. And Christina sought medical treatment at a renowned, I will say unknown cancer center, about 40 blocks south, 6 blocks east of us, with one of the leading lymphoma specialists in the country. And he outlined her treatment, which was going to include intense chemotherapy, possible radiation, some surgical biopsies, a lot of time spent isolated at home because we were going to knock out her immune system. And most tragically, for months, she wasn't going to be able to hold or cuddle her baby, because she couldn't get an infection from her. And he concluded this by saying that Christina was going to be cured. And Christina, because she had been trained at Sinai, and because she was confident, asked to be referred to palliative care. And when a doctor said, "You don't need palliative care, we're going to beat this," because Christina was brave, she said, "Yes, I do. Me, my husband, and my daughter need the added layer of support that palliative care can provide." And she quite honestly demanded the referral and sought it out by herself. Christina's cured. Her baby's walking, and the partnership between her oncologist and her palliative care doctor resulted in a far better outcome than what otherwise might have happened. And like Christina, I ask all of you to think about demanding palliative care for yourself. As I said, if this was a new medication, you'd be demanding it left, right, and center. And because if we do, and if we speak out, like we have on so many other important issues in healthcare and other issues in this country, we will, I would say, successfully transform medicine from a practice that too often sees the symptom and the disease into one which, once again, sees the person. Thank you very much for staying with me for the last 60 minutes. And for those of you who would like to leave, feel free. For those who would like to stay and ask questions, feel free to do that as well. And thank you to Susie and the West family. Thanks, folks. Mr. Baker.
What are you going to take in the future, no numbers there, in dollars, cents, and training to get to the point that you want to get to, and that I think we all want to
Yeah. So what is it going to realistically take, and in terms of both dollars, effort, personnel to get where we need to go. I think it's a lot less than we think it is, and I think there are three things that need to happen. The first is we need to be able to scale up the educational efforts like Diane Meyer is doing, and that's happening in a way that I don't think any of us could possibly imagine. 5 healthcare systems in the United States, since this has been rolled out, and it keeps getting more and more a day, have mandated this as continuing medical education for everybody in their health system. So that stimulus is there. We need a Madison Avenue, $10 to $15 million advertising campaign. This is a small example of what can happen. This is the American Cancer Society. This is their ad campaign for palliative care. But we really need to get the message out beyond halls like this. And quite honestly, we need a rapid and huge investment in research, because we can scale all we want, we can demand it, but if our clinicians, our doctors, our nurses, social workers, and chaplains don't have the knowledge and the tools to effectively treat the diseases and the symptoms we're seeing, we're not meeting the needs of our patients and families. And again, I think that is very doable. We have the National Institute of Health, the organization that you, Mr. Schwartz, the Kornfeld Foundation have funded here, the National Palliative Care Research Center, has put in a little under $15 million into research funding and leveraged $100 million, over $100 million in federal funding in 5 years. As I said, in 5 years, we've shown you can extend life, you can treat better symptoms, and there's a business case for it. So those are the three things that really need to happen, Jay, and I think they can happen very quickly. Yes, ma'am.
You said that we should all get our legislators to get more money than palliative care. I'm wondering if there's any organization that is conducting such a campaign.
The question is, I said something about asking your legislatures to get involved. And is there an organization conducting a campaign? The answer is yes and yes. So the first thing to know that there is legislation that sits within the House and the Senate that is asking for exactly what I said here, that would direct the NIH to fund palliative care research, that would set up palliative care centers of excellence to do the education that we asked for, and would promote a national marketing campaign. That has extensive bipartisan support in the Congress. It was just introduced with bipartisan support in the Senate 2 weeks ago, so that the Patient Quality of Life Coalition, which is an organization of now 40 different patient, physician, medical organizations, and the American Cancer Society, were behind that. So it's not even, there's a straightforward ask, and I'm not allowed to lobby for a bill because I'm at Mount Sinai, but I will say there is a straightforward ask to be made. There is legislation. It is easy for your senator or congressperson to sign on to it. It doesn't cost the government a lot of money, and it sits in Congress, and you can decide what you would like to do with that information, and I'm happy to tell you what the bill numbers are. Jennifer. Yeah. Jennifer. Hello.
As they are in my mind, in the American imagination, and is that a problem for your...
Yeah, so the question is, what's the difference between hospice and palliative care? Are they connected in the minds of the American public, and should they be? The answer is yes, yes, and maybe. Hospice is a fabulous system of care, but it's really limited to those right at the end of life. And typically, although it's a 6-month benefit, as physicians, in order to make that referral, we're really good at prognosticating somewhere about a month before death, which is why the median length of on hospice is really sort of short. But it's a fabulous system, and we should be making referrals a lot earlier. But it's limited to the fact that it's a prognostically based, that is, you have to figure out when somebody is going to die in order to get them into hospice. Palliative care is much more extensive, so that A, you don't have to be dying. B, like Christina, you can expect and should be expected to be cured. but get that added layer of support, or B, you have a serious or chronic illness that's going on a long time. I think they work hand in hand really well together, because obviously as the disease progresses, that handoff or that partnership with hospice is incredibly important. But it is really important in terms of thinking about them as different systems of care right now until the Medicare hospice benefit is changed. Does that answer your question?
Yeah, except that I mean, can you decouple them and do mine somehow? Or is that even a problem?
Can we deep? It is when we did. Yeah, the question was, can you decouple them in patient's mind? The answer is yes. The other important point to that is this is a pretty sophisticated audience. But when we did a national survey of the American public, 78% had absolutely no idea what palliative care was. Couldn't even define it, which I'm told in marketing is not such a bad thing because you don't have to rebrand, you can start to brand. So I think you're right. I think that is an issue, but I think for this people who are much more medically knowledgeable, yes, we really do need to think about decoupling them for a number of reasons. I can't see it.
Could you explain how palliative care and pain management coexist at our hospital and generally at other hospitals?
So the question is, can I explain how palliative care and pain management coexist, both at our hospital and at other hospitals? They attack different problems. So pain specialists are focused on people who really have one symptom, and that is pain. And it's typically in two groups. One is working with acute surgical pain and managing pain after surgery. And the other is what we call chronic pain syndromes, and the prototypical example for that is low back pain. Palliative care teams take care of people with serious medical illness for which pain is typically, and most often is, just one of many different symptoms. So palliative care teams are expert in pain, but they're not quite as expert in pain as, for example, an anesthesia pain team. We don't do invasive pain blocks the way an invasive pain team does. And at this institution, we collaborate really well. If it's a straight pain problem, if it's a post-operative pain issue, our anesthesia pain team sees it. If it's somebody with complex, serious medical illness and pain is one of any other symptoms, we see them. And if we need an intervention for somebody with serious illness and multiple other symptoms who could use a fancy pump or block, we'll have our pain team put it in.
Thank you. I hope I can phrase this properly. I'm not a healthcare professional, but I've worked for the last 13 years with children in palliative care. It is like pushing a boulder up a hill. And after attending a seminar at Calvary Hospital 2 weeks ago, I finally got a straight answer out of somebody about the mindset about pediatric palliative care. And it reminded me of what I've known for the last 13 years, which is children shouldn't die, so we're not going to even consider palliative care because it's just not going to happen. Sadly, it does all the time. How do we get hospitals, institutions, people's mindsets to agree to having a palliative care service for children? They'll have one for adults, but they won't for children.
Yeah, children shouldn't die. I mean, we all know that. On the other hand, there are many children in this country who have serious illness, and I think the key to getting palliative care to children, the same way it is to getting palliative care to adults, the same way it is to getting palliative care to people who are undergoing intense treatment for curative purposes, is to continue to emphasize that the goal of palliative care is to improve quality of life in the setting of serious illness and provide an added layer of support. And that is not about how long you have to live or where you are, but it is really about enhancing quality of life. And I think because children are little, and because there are not a lot of them who are seriously ill, thank God, there is a very small evidence and research base, and there is a very small clinician base of palliative care specialists who work in that population. And I think, if I were thinking about where is there to be a major investment as well as what we're doing, it would be in pediatric palliative care. I mean, I talked about the evidence base for adult palliative care. Pediatric palliative care is 1/100 of that. It just doesn't exist. But in answer to your question, it's about improving quality of life and providing the added layer of support. And I think that once you do that, you can get past that barrier. The other barriers about workforce and evidence come as well. Let me do one more question. Ms. Sidero.
Dr. Morrison, could you talk about how the Affordable Care Act and the move towards value-based payments and focus on quality presents an opportunity for palliative care?
Yeah, so the question is, what are the opportunities under the transformation in healthcare that we're seeing for palliative care? And I think they're quite real, and they're quite vast. So what the Affordable Care Act has done for this population is transition us from where we get paid for every single intervention, test, procedure that we do to a focus on getting paid for quality and value. And that for palliative care teams who have been exclusively focused on enhancing quality of life, it has been a door opening widely in terms of being able to meet the goals of the ACA. Now, that being said, we have not transitioned from fee-for-service medicine to value-based purchasing yet. I would say we're about 30% of the way there in New York, if that. So the barriers are still there. But I think for the first time in medicine, we do see a payment system that will allow palliative care teams to be somewhat compensated, or I'd say appropriately compensated for the care that they're delivering, as opposed to now where the only piece that's really compensated is part of the physician's salary. So I'm not going to keep anybody anymore. I am happy to answer questions at the front if people have them, and thank you again.